Okay, so our goal for today's lecture is to finish up the discussion of reproductive anatomy, going into the intricacies of female reproductive anatomy and physiology, and discuss a little bit about contraception and kind of preview or introduce embryology and embryological terms and kind of just the basics of the developing zygote as it matures into an embryo and then ultimately a fetus in the later stages of pregnancy. But we'll probably end up saving most of that for our final lecture on Tuesday. So yeah, we're coming in on the home stretch here. We've got this lecture and then next Tuesday, and then we're done. I do want to leave a little bit of time today for like some questions and answers. If you guys have questions or are curious about things like contraception and STIs, or sexually transmitted infections, or those sorts of things, let them fly. Like there's no weird or abnormal questions. But if you guys are interested in those things, you can go ahead and throw them out there. Okay, so we're going to pick up here with our mid-sagittal section through the female pelvis. All right, so here we've got some obviously different structures compared to the male, but we are going to see some similar things. Like we have our pubic symphysis here. We've got some perineal musculature right around here, kind of closing around the rectum and then the anus over here. So all of that is still the same, but we have a mainly different structure in the form of the vaginal canal and then the vaginal vestibule or the vulva, and then ultimately the uterus connected to the fallopian tubes and the ovaries up here. So just really quickly, kind of how this is laid out. The bladder sits anteriorly relative to the uterus, okay? And then we have a little omental bursa back here, so a little pocket between the uterus and the descending colon over here. And that's intentional to allow for expansion to accommodate pregnancy, to accommodate the developing fetus during pregnancy, okay? So, but conversely, the bladder unfortunately gets squished down on as a fetus is growing inside of the uterus, okay? So, but we've got some other structures to talk about here. So we have our uterine tube up here, which is connected to the uterus itself. Sometimes it's called the fallopian tube, potato, potato kind of thing. The little extension right here, these little fibrous extensions are called fimbriae. And then this little large extension right here is called the ampulla. So it's not labeled on this image, but that's what those things are called. And those are important because the ampulla is where most normal, not pregnancies, but most normal fertilization events or conception events occur is in the ampulla, this little extension of the ovarian tube right here. And then the ovary, which we'll talk about in detail in a little bit, is going to release eggs that enter, when everything's functioning properly, they're going to enter the uterine tube here through the extension of these little fimbriae, right? So they're going to grab onto the ovums as they are being ejected from the ovary. And then if a fertilization event occurs, that now what we call a zygote, the fusion of the sperm and the egg, will then travel down the uterine tube and implant itself within the uterus and then grow and develop into a zygote and then a fetus and then ultimately a living human thing, right? So the extension of the uterus here ends in what we call the cervix. So that's kind of the posterior region of the vaginal canal. So the little cervix is going to provide a barrier between the vaginal canal and the inside of the uterus. So there's a connection called the isthmus of the isthmus of the cervix, and so that's the direct opening from the vaginal canal into the uterus, and that's what eventually dilates during labor. And then we've got our vaginal canal here, made up of mostly smooth muscle, and it's got some mucosal layers that are going to provide secretions and liquids and different kinds of mucuses that will lubricate the vaginal canal for intercourse. And the vaginal canal itself will actually elongate during sexual intercourse, and it can shrink when a female is not aroused. And so it can change in size. It's a fairly plastic structure. It can change depending on what's going on with the female at a given time. So then at the isthmus, or the entrance of the vagina, called the vaginal orifice, the vaginal vestibule. Then the external genitalia is comprised of what we call the vulva, right? So that's going to be consistent of things like the labia majora, or the big lip. So that's what this is called out here. And then the labia minora, or the small lip, which is going to be internal and slightly medial relative to the labia majora. Okay, so we'll talk about those in a little bit more detail here in a bit. But then from the vaginal orifice here, just anteriorly to that, we have the urethral opening right here. So this is the urethral orifice that connects directly to the bladder right here. So what's interesting about females compared to males is that the urethra is much smaller in females. It's only a few inches at most, and this is one of the reasons why UTIs can be quite common in females, because of the length of the the length of the urethral canal here, and its connection to the vaginal orifice. So secretions from the vaginal canal can end up infecting the urethral orifice here, and then cause things like urinary tract infections. Other things can account for that as well. Things like semen can also account for urinary tract infections as well. And then we have most superiorly, we've got our clitoris right here. So the clitoris sits right on the top of the vulva, and it's made of the same the same erectile tissue as the glans penis, and will become engorged with blood during sexual arousal and during sexual intercourse. Okay. What else? What else are we going to talk about here? So we've got some adipose tissue that's present here, right? So we can see the deposition of adipose tissue. The female here is a little bit more pronounced around the hips. Okay. Okay, I think that's all we're going to talk about here for now. Okay, so here we've got a coronal section through the uterus, the canal of the cervix, and the cervical opening, with a little bit of vaginal canal here as well. But we can see into the body of the uterus right here. So the uterus itself is fairly small when it's not, carrying a growing child, and can obviously change in size to accommodate those sorts of things. So the uterus itself is made up of 3 different layers of tissue called the endometrium, endo within, metrium referring to myometrial or mesentery associated with the uterus. And then we've got the muscular tissue called the myometrium right here, and then the parametrium, which is the outer layer of connective tissue. So it's what we call a serous layer. It's also very similar to the visceral peritoneum. It's technically the exact same thing, but it is just called the parametrium to be specific relative to the uterus here. So then over here, even on top of the visceral peritoneum right here, or the parametrium, we have something called the broad ligament, or the uterine ligament. So this blue clear connective tissue covers everything, covers all of the stuff that we end up seeing here. So the broad ligament covers everything. It is a broad structure. Not only does it do that, it covers the anterior side, it also goes around and covers the posterior side of the uterus and the fallopian tubes over here. Okay. So that being said, there's a lot of suspensory and support ligaments that are associated with the uterus and the fallopian tubes and the ovaries. Namely, so behind or posterior to the ovarian, or the broad ligament here, and actually if we kind of take a sec to look at the smaller image on the top left part of the screen here, we can see that we've got our uterine ligament right here, our uterine tube, and just inferior to that we have something called, it's not labeled, but it's called the mesosalpinx. It's a specific extension of the broad ligament that connects the uterine tube to the broad ligament, and then ultimately to the ovary. The ovary itself is supported by its own ligament called the mesovarium, or some people call it the mesovarium, right? So there's a lot of different ligaments in here that all get their own nomenclature, but it's all kind of extensions off of this broad ligament, right? So the fundus, or the curvature of the uterus, is just up here on the kind of posterior side, or I should say the most superior aspect of the uterus. Okay, we've got a uterine cavity, the extension into the fallopian tube, or the uterine tube. So as I mentioned before, the uterine tube, as it gets close to the ovary right here, it kind of expands into a little pocket that we call the ampulla. And this is the most common place for conception and fertilization. And then we have a direct connection to the ovary right here via the fimbriae of the fallopian tube right here. So they're little tiny filamentous extensions of this that during an ovulation event will receive the egg and deposit it into the ampulla of the uterine tube, okay, to await for fertilization. Okay, so yeah, we can see our round ligament cut just here and the ovarian ligament just back here. Let's see, what else? Yeah, that's pretty much it for here. So body of the uterus, fundus, and the cervix. So for clinical reasons, the cervix is technically considered part of the uterus as well. Okay, so here we've got a cross section through a ovary that contains or shows a lot of things going on here, right? So this is showing us that all around the outside we have all of these little primordial follicles, okay? And each of these follicles will eventually mature into an ovum or into an egg cell. But in order to do that, they have to undergo mitosis and meiosis in order to do that. And so each one of these little extensions or these little images right here shows us a primordial follicle undergoing different stages of the maturation of that follicle until ultimately it matures into a secondary oocyte, and that will eventually produce what we would call a functional egg. And then once that egg is produced, we have the extension or of the follicle or the remnants of it that kind of transform into this structure called the corpus luteum. Okay, so if pregnancy occurs, the corpus luteum is important for hormonal signaling to prepare the uterus for implantation. But if pregnancy doesn't occur, then the corpus luteum degrades and will end up being shed with the uterine lining during menses. Okay, so let's kind of go around some of this, and then I'll get to some of these things on the side over here. Okay, so yeah, we've got our mesovarium, so the ligament that's going to be suspending and supporting our ovary right here, and you know the ovaries are definitely living tissue, so they've got a rich supply of blood that's going to them. And so these primordial follicles during each month of menses will end up being signaled to undergo mitosis and meiosis in order to grow and mature to become a mature egg cell. So this primary oocyte here is going to be kind of one of the first stages of that. And then these primary follicles that end up developing end up becoming a layer of cells that we call granulosa cells. And then there's a little liquid layer that forms around the primary oocyte here that we call the zona pellucida. Okay, so it's a little bit of nutritional layer for the growing oocyte here, right? So then ultimately, what ends up happening is that will end up dividing via mitosis, and then one will kind of form this non-functional bit that ends up degrading, and that's what we see here in our degenerating follicle. Okay? So the one that's going to end up participating in an ovulation event ends up becoming what we call the secondary follicle. So we've got our secondary follicle that develops here, and we have all of these liquid or viscous vesicles that end up forming right here that are going to create this second bit of the mature follicle, or what we call a Graafian follicle. But this little oocyte right here is going to end up being the mature egg cell that gets released into the ampulla of the uterine tube to undergo a fertilization event. Okay, so we've got other layers of cells called cumulus cells, and this large liquid portion right here is what we call the antrum. All right. So this mature follicle right here, this entire thing ends up getting released into the ampulla. Right. So it's a much larger cell body compared to the sperm cell. Right. So we've got all this information right here that's all collected right inside of our primary oocyte, right? So then as that gets released into the ovarian tube, then during sexual intercourse, the sperm cell will then penetrate the barrier surrounding this mature follicle and then cause that fertilization event to occur. But if it doesn't, then the entire thing gets shed and transformed into the corpus luteum. Right here. Okay, so yeah, let's see. So each ovary has hundreds of ovarian follicles, which house each of the egg cells. And so each of these structures must mature in order for ovulation to occur. So we're going to go into that in some detail here in a sec. So one common disease that can affect the cervix in females is something called human papillomavirus, and it can affect the reproductive tract epithelia and can affect oropharyngeal tissue as well. It's a really simple vaccination that you can get. You can get it, just generally, with like a general practitioner or anything like that. Probably not so much right now, given the pandemic. But there's very safe vaccinations that you can get that will help you, prevent the spread of HPV, right? So type 16 and 18 are definitely the most dangerous ones, and the vaccination, helps treat against most of them. Okay, so here we have what's happening in terms of the oocyte maturation and then in terms of the follicle maturation. So the oocyte itself is contained within the follicle, right? So just to kind of like wrap our heads around this, what ends up happening during an ovulation event to prepare for that is the menstrual cycle. And so the menstrual cycle is the female body's response of getting ready to become pregnant, right? And this typically happens, every 28 days, but it can range between, the low end 18 days and sometimes upwards to 40 days, right? It's completely variable, and it's somewhat uncommon to have. Or actually, I shouldn't say that it's somewhat uncommon. I can't comment on that for sure. But I know just from personal experience, and a lot of the women that I know in my life, menstrual cycles are seldomly regular, right? So what we end up having occur on a cellular level on the left-hand side here is we have these little egg stem cells that we call oogonia, right? So the oogonia end up cloning themselves through mitotic division during development as a fetus, okay? So then what ends up occurring during fetal development is females will end up producing all of the egg cells that they're going to have for their entire life. So it's up to about 5 million egg cells, right? So at around 4 months, the fetus ends up developing about 5 million oogonia, right? And then once the female ends up maturing and ends up becoming a fetus and then is birthed successfully, then we end up losing quite a few of those oogonia. So about 3 million oogonia are just lost by the time the developing female fetus ends up being birthed, right? So just in that short amount of time, those 5 months, you lose up to 3 million of those oogonia, right? And again, females aren't able to produce any more of those throughout their lifetime. What you're born with is what you have, okay? And then to kind of kick you while you're down, there's no additional development of these cells, and by the time females reach sexual maturity or puberty, they lose several more million. So they end up from birth to puberty with only about 300,000 to 400,000 primary oocytes, okay? So the other thing to think about is the primary oocytes here are actually not even the egg cells that end up getting released during the ovulation event. It's only the secondary oocytes that get released during an ovulation event. And of those 300 to 400,000 primary oocytes, the amount of functional secondary oocytes on average is only around 400 by the time a female reaches sexual maturity. So right around that time, that's the rough amount of successful secondary oocytes that are going to be released during an ovulation event, okay? To put that in perspective, from the amount of oogonia, the amount of egg stem cells that a female starts off with during development as a fetus, right? You end up losing 99.99992% of the total amount of eggs there. So you are left with 0.00008% of the eggs that you kind of like start out with in utero, right? Which is kind of crazy to think about, that is the scale of reduction in terms of successful ovulation events that you are allowed to have, right? It's kind of insane that's the only amount, right? Like that's what you're born with, that's what you have, and on average, you end up having only 400 successful ovulation events. So it's kind of crazy to think about. Okay, so let's kind of walk through a little bit what's going on during development right here. Okay, so oogonia, these are like egg stem cells, give rise to oocytes, right, which are going to be like kind of our cells that transform into our egg, right? During development of the fetus, many oogonia begin meiosis, but stop during prophase 1 and then become primary oocytes right here. So they remain in this state until puberty. And before birth, the primary oocytes become surrounded by a single layer of granulosa cells, creating that primordial follicle. These are present until puberty, right? So that's what we're seeing over here. And if you recall on the previous slide where we sectioned through the ovary, that's what we end up seeing around the perimeter of the actual ovary, right? So each of those primary oocytes are surrounded by these granulosa cells, and those together are what we call the primordial follicle. So each one of those are going to end up developing, hopefully, into a successful secondary oocyte. So once the female reaches puberty, the primordial follicles develop into primary follicles, okay, where the granulosa cells enlarge and increase in number and size. And they'll form these stratified cuboidal layers of epithelia right here, so these granulosa cells. That zona pellucida forms, that little liquid layer, around the primary oocyte as well. So secondary follicle forms when fluid-filled vesicles develop and the theca cells arise on the outside of the follicle. So the theca cells are out here around the outside of the follicle, and then the fluid-filled vesicles form here. Okay? And the mature follicle forms when the vesicles all unite and create a single fluid-filled cavity that we call the antrum. Okay? So just before ovulation, the primary oocyte completes meiosis 1, right? So creating a secondary oocyte and a non-viable polar body, okay? So those polar bodies can end up dividing, further on, but they are not actually used to create a viable oocyte. So only one of them becomes the successful secondary oocyte. So the secondary oocyte begins meiosis 2, but then stops at metaphase 2. And then during ovulation, the secondary oocyte gets released from the ovary, okay? So that's what we end up seeing over here. So during ovulation, that gets released from the ovary. And then finally, so it's not pictured here, the secondary oocyte only completes meiosis 2 if it's fertilized by the sperm cell, right? So if the sperm cell ends up being able to fuse with it, then it can complete the second round of meiosis, okay? So the completion of meiosis 2 forms an oocyte and then a second polar body right here. So these polar bodies are kind of non-functional forms of these oocytes. They end up going off and then being degraded over time. Fertilization is complete when the oocyte nucleus and the sperm cell nucleus unite, thereby creating a zygote that goes from having 23 individual chromosomes to 46 chromosomes in total, right? So this is where we end up combining the genetic makeup from mom and dad. So following ovulation, the granulosa cells divide rapidly and then enlarge to form the corpus luteum. The corpus luteum will eventually degenerate and form a scar called the corpus albicans. Okay, so the zona pellucida here ends up kind of degrading, and then that secondary oocyte will then either get fertilized or not. And if it's not fertilized, then it's shed with the endometrial layer during menses. Okay, and then as I mentioned before, if pregnancy occurs, that corpus luteum is important for hormonal signaling to prepare the uterus for implantation. But if not, then either way, it ends up degrading and forming that corpus albicans and ends up getting shed with the uterine lining as well. Okay, so here we have the vaginal vestibule. So as I mentioned before, on the outsides here, we have the labia majora, right? And then just medial to that on these inner layers, we have the labia minora, right? So two sets of lip-like tissue on either side of the vaginal vestibule, okay? And then inside the vaginal orifice right here, we have the vaginal canal opening, and then just superior to that, we have the urethra, and then ultimately the most superior structure here is the clitoris, protected by the clitoral hood, or the prepuce of the clitoris, right? Which would be serially homologous to the foreskin of the penis of the male, right? And then we have a layer of adipose tissue underneath this area on top of the pubic bone that we call the mons pubis right here, okay? Okay, so moving right along, we go into mammary tissue, all right? So mammary tissue has a rich network of lymphatic vessels, lymphatic tissue, and adipose tissue. And so we have special sets of cells called myoepithelial cells that end up creating secretions that that end up being used for production of milk, or milk letdown, or lactation, okay? So the lactating breast will end up producing a lot more, obviously, milk or lactation during different times of the month, and then obviously after or after birth, right? So the milk letdown process will occur even before birth as well. Okay. So these lactiferous ducts are surrounded by multiple little lobules of alveoli tissue that end up producing milk via miracrine secretion. So that so little tiny portions of these cells end up breaking off and forming the lactation, or forming milk, right? So non-lactating breast up here, a little bit reduced in size, but also does not have the areolar tissue of the, I'm sorry, not areolar, alveolar tissue that's utilized during lactation. Okay. Also, to simply check for breast cancer, if you notice any sort of abnormal lumps, that's something that you definitely want to get checked out. Sometimes they're benign tumors, sometimes they're malignant tumors. Close family friend of ours actually was just diagnosed with breast cancer. She noticed a nodule, and she luckily caught it early enough to be able to not have to undergo chemo or surgery or anything like that. And she just has to go through radiation every day. So it's tough, but she caught it early enough so that she doesn't have to have any any chemotherapy or anything like that. Okay. Also notice how the breast tissue sits anterior to all of the muscular tissue of the chest cavity here as well. So the pectoralis major, pectoralis minor as well over here in the intercostal muscles here too. Okay, so some events of the menstrual cycle. So the menstrual cycle is kind of broken up into 4 different stages, with the ovulation period occurring kind of like right in the middle. So the first 4 to 5 days of the menstrual cycle is what is known clinically as menses. So this is where the pituitary gland has the rate of follicle-stimulating hormone and luteinizing hormone at a low level of secretion, but the rate of follicle-stimulating hormone secretion increases as progesterone levels end up declining during the beginning of the menstrual cycle. Okay? So the rate of estrogen and progesterone secretion is low within the ovary as well, after degradation of the corpus luteum produced during the previous menstrual cycle. The uterus itself, in response to declining progesterone levels, has its endometrial lining of the uterus slough off. So this results in menses, followed repair of the endometrial layer. So each month during that time of bleeding, then what ends up getting released during that process is the lining of the uterus. And that lining is important because it provides nutritional layer for the developing zygote to be able to implant into. If it's not needed, then it ends up getting shed to be able to be produced anew, to provide a new layer of attachment for a new potential zygote. Okay. So then we have the proliferative phase. So from day 4 or 5 until ovulation on roughly day 14 of the menstrual cycle. So the pituitary gland has the rate of follicle-stimulating hormone and luteinizing hormone is only slightly elevated during most of this phase. Follicle-stimulating hormone and luteinizing hormone secretions increase near the end of this phase in response to increasing estrogen secretion from the ovaries. So as we reach closer towards ovulation, follicle-stimulating hormone and luteinizing hormone end up being increased in secretion. Developing follicles within the ovary secrete increasing amounts of estrogen, especially near the end of the proliferative phase, increasing follicle stimulating hormone and luteinizing hormone, causing additional estrogen secretion from the ovaries near the end of the proliferative phase. So we end up seeing here is that estrogen has a positive feedback loop on itself. So as the uterus is getting closer and closer to preparing for ovulation, or I should say the ovary, the amount of estrogen secretion goes up, which is going to cause more follicle stimulating and luteinizing hormone to be released, which then cause additional estrogen to be released as well. So then the uterus causes, or the estrogen causes endometrial cells of the uterus to divide, so preparing a new endometrial lining. The endometrium of the uterus thickens and tube-like glands form. The estrogen will cause cells of the uterus to be more sensitive to progesterone by increasing the number of progesterone receptors in uterine tissues. Okay. So the pituitary gland then during ovulation on roughly day 14, so the amount of follicle stimulating and luteinizing hormone during an ovulation event is at an all-time high. So just before ovulation, it increases rapidly in response to increasing estrogen levels. Increasing follicle stimulating and luteinizing hormone levels stimulate estrogen secretion, resulting in that positive feedback cycle. Luteinizing hormone will then cause final maturation of a mature follicle and initiates the ovulation process. So all these hormones at these levels are key to allow for an ovulation event to occur. Follicle stimulating hormone acts on immature follicles and causes several of them to begin to enlarge. The endometrium will then continue to divide in response to estrogen, so getting ready for implantation. So after an ovulatory event, we undergo the secretory phase. Okay, so this is like the last stage of the menstrual cycle before everything begins again, and then the uterus prepares to slough off the endometrial lining. So the pituitary gland, estrogen and progesterone levels reach high enough to inhibit follicle stimulating luteinizing hormone from the pituitary gland. So these hormones reach high enough levels to initiate that negative feedback loop. After ovulation in the ovary, the follicle is converted into the corpus luteum. Corpus luteum secretes large amounts of progesterone and smaller amounts of estrogen from shortly after ovulation until about day 24 or 25 of a 28-day cycle. If fertilization does not occur, the luteum degenerates after about day 25, and the rate of progesterone secretion rapidly declines to low levels. Okay? So within the uterus, in response to progesterone, the endometrial cells enlarge and the endometrial layer thickens, and the glands of the endometrium reach their greatest degree of development, and thereby the endometrial cells secrete a small amount of fluid to prepare themselves for implantation. After the progesterone levels decline and there's no implantation event that occurs, then the endometrium begins to degenerate and begins the sloughing off process. So graphically, that's what we end up seeing occurring over here. So what we can see on the left-hand side here, we've got on the bottom, we have the layers of the uterus itself. And then within the ovary, we have hormone levels, progesterone and estrogen. Then we have our developing follicle, and then in the pituitary gland, right? So during the first couple of days of the cycle where we have menses, so this is the end of the previous menstrual cycle, we have the bleeding process that occurs where the endometrium of the previous menstrual cycle is being sloughed off and we're getting prepared to start anew. Then roughly between days like days 4 to 5 and then up to the ovulation event, this is our proliferative phase. So progesterone and estrogen aren't really doing too much, they're increasing slightly, and then the follicle stimulating and luteinizing hormones are slightly increasing as well. But within the ovary itself, this is where we have our follicle development that's occurring. And then the maturation of that secondary follicle here is triggered once the endometrium gets thick enough to be able to support it, and then these hormone levels end up spiking. So estrogen, follicle stimulating hormone, and luteinizing hormone all spike in response to this process to prepare for that ovulation event. Okay, so progesterone has a little bit of a lag time before it peaks to prepare itself for the secretory phase, because ideally the progesterone levels are going to prepare the uterus for implantation. So a little bit of a lag time here is necessary to allow for fertilization to occur. Okay, but if no fertilization event occurs, then the corpus luteum of the secondary oocyte here degenerates into that corpus albinea, or I forget what the name of it is, but corpus albicans. Corpus albicans. So that will end up degrading, and then eventually, if no implantation occurs, then the endometrial layer is sloughed off again, and then the entire process starts anew after around 28 days. Okay? So, with the menstrual cycle, there are unfortunately a lot of things that can go wrong with it. Okay, the entire absence of the menstrual cycle is something called amenorrhea, and this can come about for a variety of different reasons. Some of the more common ones are hormonal disorders, but even things like extraneous exercise or stress can cause abnormal menstrual cycles. Tumors are obviously, a big issue as well, but a lot of the more common ones are hormonal disorders. So the improper function of the pituitary gland will definitely contribute to this, because without these luteinizing and follicle stimulating hormones being released here, estrogen levels and progesterone levels don't really change that much. And then the menstrual cycle won't actually begin if it's not able to, slough off any of this stuff, or any of these hormones aren't actually being produced at their levels that they need to be. So some issues with that is if the endometrial layer isn't allowed to slough off, an abnormal condition can occur called endometriosis, where sometimes the endometrium isn't sloughed off and is not, gotten rid of during the menses portion of the menstrual cycle. And sometimes this tissue can end up grafting to other structures inside of the peritoneum. So what that means is these endometrial cells can then graft onto parts of the intestines, can graft onto the outside of the uterus, sometimes even the ovaries or fallopian tubes. And the annoying thing is that these endometrial cells will still respond to hormone levels that will cause them to want to bleed during each day, or each of the sets of the menstrual cycle, or each days of menses rather. So that's obviously bad, because you can have, strong internal bleeding, which I would imagine is probably quite uncomfortable. But not only that, you can have, internal hemorrhaging if it progresses to a severe point. But also you can have tumors develop, because this tissue is causing, still has blood supply, and those cells are still present. And if they're not functioning normally, that's a breeding ground for cancerous cells to be able to be produced there. Okay, so another fairly common disorder of the menstrual cycle is something called polycystic ovarian syndrome. Oops, there we go. Or polycystic ovary syndrome, or PCOS. So this is a little bit more common than you would think, but PCOS is basically where ovaries will have an abnormal amount of cysts on them. Ovaries themselves normally, as we just saw, during the developmental stages, they produce cysts as a part of their developmental process, right? So that's normal, but where you have an increased amount of these cysts that develop, that's where we have polycystic ovary syndrome come into play. And a good way to think about this is the ovary itself is kind of like a chocolate chip cookie, and you've got little chocolate chips all over the place. And a normal chocolate chip cookie doesn't have too many chocolate chips on there. It's like an even, spread of them. But a polycystic ovary looks like a chocolate chip cookie with just like a ton of chocolate chips thrown on it. And so each one of those chocolate chips normally would end up being able to mature into a secondary oocyte to be able to be a viable ovum. But if you have too many of those, and too many of them rupture, they can interfere with the healthy secondary oocytes that are supposed to be getting released during an ovulation event. Okay? But some of the common occurrences, or common things that can contribute to PCOS, are things like hormonal imbalances. Sometimes estrogen and progesterone levels are too low. Sometimes other sex hormones are too high, like testosterone. Usually it's the testosterone levels that are a little bit elevated, and so some common side effects of this are things like weight gain and male hair development. So women with PCOS will tend to have, a little bit more facial hair that develops. They can grow a little bit more facial hair all over their body as a result of this. The other thing as well that's indicative of PCOS is you can still have a menstrual cycle, but you will not actually ovulate during the menstrual cycle. So as I mentioned, part of this ovulation process, as that secondary oocyte gets evacuated from this layer of cells here, then the fimbriae of the uterine tube have to actually connect and attach to that secondary oocyte in order to bring it into the ampulla for fertilization. If that doesn't occur, then there's not going to be any chance of fertilization of it. So that's an important thing to note there, is that you can still have a menstrual cycle, but still not actually be ovulating as a result of that. So that could be, that could cause, some other issues as well. If you have internal bleeding as a result of that, the fimbriae aren't technically attached to the ovary, then that's what ends up causing that. And so there's a host of different clinical tests that you can do to account for this, and you can get different kinds of testing done to see, if this applies to you, what kind of situation you're dealing with. But yeah, like there's a ton of stuff that goes on with menstrual cycle, with ovaries, and all different kinds of things go on. So yeah, PCOS, a fairly, unfortunately fairly common instance of abnormal menstrual cycle. People who have severe eating disorders as well, like anorexia, can develop amenorrhea and not have a menstrual cycle for prolonged periods of time too. Yeah, so then here's our big table again with all of our stages of the menstrual cycle. Okay, so another, abnormal form of the menstrual cycle is menopause. So usually women who, reach their 4th and 5th decade of life will undergo menopause, where they'll stop having a regular menstrual cycle. That's due typically to hormonal changes. So 5 to 7 years before menopause, the cycle becomes irregular, and the number of cycles in which ovulation does not occur and into which corpora lutea do not develop increases. So the corpora lutea, again, is important for successful implantation. The uterus itself has gradual increase in regular menstruations and followed by no menstruation. The endometrium will finally atrophy and the uterus becomes smaller as a result. The epithelial lining of the vaginal canal and external genitalia becomes thinner. The external genitalia become thinner and less elastic, and the labia majora becomes smaller. Pubic hair will decrease. Reduced secretion leads to vaginal dryness, and the vagina can become more inflamed and infected because of the lack of epithelial cells that are producing those mucosal secretions. The epidermis will become thinner, so skin becomes thinner. You can develop hypertension and arteriosclerosis. Hot flashes and increased sweating are correlated with vasodilation of cutaneous blood vessels. The hot flashes are related to decreased estrogen levels. So as estrogen declines, this is one of the causes for hot flashes occurring. So as those vessels within the cutaneous cells, or the cells underneath the epidermis, become dilated, then you end up having these hot flashes as a result of that. Usually there's a small decrease in libido or sex drive, and typically that's associated with the onset of menopause. And so fertility begins to decline about 10 years before the onset of menopause. So this is roughly around age 40. And then by about age 50, almost all the oocytes and follicles have completely degenerated, right? So by about age 30, women have lost typically about 90% viable primary oocytes that are going to be able to be utilized for a fertilization event. Okay? And then the pituitary gland function changes. So we have low levels of estrogen and progesterone that get produced by the ovaries, causes the pituitary gland to secrete larger than normal amounts of luteinizing and follicle stimulating hormone. Increased levels of these hormones have little effect on the postmenopausal ovaries. But also, what a common side effect of menopause is ovarian cancer. So you can get ovarian cancer, tumors will develop on the ovaries, you can get uterine cancer as well. So part of the issue with that is sometimes you have cysts and tumors that develop that can cause cancer. And so a common procedure that occurs after, or usually it can sometimes be used as like a preventative measure if you're at risk for developing these tumors before menopause, which is something called a hysterectomy. And then so a hysterectomy is removal of just the uterus and the cervix, as well as I believe the fallopian tubes are removed as well. And then sometimes, or usually during a hysterectomy, the ovaries are left in because the ovaries are important for things like estrogen and progesterone levels. But sometimes the ovaries, if they're at risk for developing a high amount of tumors, then the ovaries are removed as well. And that procedure is something called a hysterosalpingo oophorectomy. I'm not making that word up. You can Google it. But that's the removal of all of that stuff from the abdominal cavity. Okay. Okay, so kind of shifting gears here. If we talk about orgasms for a second, which I know is kind of like, whoa, what? We just talked about menopause, and now we're talking about orgasms. Yeah. Orgasms have very similar neurological responses within males and females. Typically you have muscle tension develop throughout the body, and intense moments of euphoria. You have different neurochemicals that get released, oxytocin, serotonin, all these other hormones that get released to cause these moments of intense euphoria during orgasm, right? So the clitoris, in the females, clitoris and labia become engorged with blood, very similar to the erectile tissue in the male, with the corpora cavernosa becoming engorged. And then we have parasympathetic and sympathetic innervation that become play a big role in determining the degree of the orgasm, right? And so, with both sets of orgasms, males and females can both have the moment of orgasm, and then there's a moment of resolution where you cannot physically achieve an orgasm again for a set period of time, and it varies between individuals. But females, for the most part, are actually able to achieve successive orgasm, relatively quickly, depending on the situation, right? And so males are also able to achieve successive orgasms, but not to the same degree as females, right? So a little fun fact there. Okay, so now we get to have the fun conversation about contraception. Okay, so we've got several different kinds of contraception or contraceptive methods. All right, and so whatever your beliefs are, there's a whole lot of different methods out there, and I'm not trying to tell you which way is right or which way is wrong, but these are just some of the methods that are available if this is something that you're interested in. Some people still practice abstinence. Abstinence is just the total lack of sexual intercourse or sexual contact whatsoever. But there are plenty of studies out there that show that especially high schools who teach abstinence-only sex education have some of the highest rates of teen pregnancies. And there's nothing wrong with teen pregnancies, but that just goes to show you that if you are trying to prevent teen pregnancy, if that's one of your goals, then teaching abstinence only is not an effective measure, right? So some of the more common prophylactic measurements that people will take are things like male condoms and then female condoms, right? So sometimes usually what these are made out of is mostly latex. They used to actually, back in not too long ago, like the early or like late 1800s, early 1900s, condoms were made out of things like goat skin. Sometimes they were made out of pig intestine or sheep intestine. And to boot, they were actually reused. They would wash them and then reuse them, the next time they were, out and about and doing their thing. So, these are some of the more common prophylactic measurements that people take. Typically, male condoms and female condoms are present as well. There are also things like diaphragms. So diaphragms, their goal is to sit back and cover the inside or cover the outside of the cervix to prevent any sperm from entering the cervical canal and then getting into the uterus and then up through the fallopian tube into the ampulla of the ovarian tube. Right? Okay, so we've got some other, oral contraceptives that can be effective as well. There are, different kinds of vaginal inserts that will release different hormones at different levels to be able to, control the menstrual cycle or control the ovulatory part of the cycle to prevent any sort of egg to be released during the ovulation cycle. There's also the morning after pill, which is considered to be a pretty effective contraceptive measurement. And then let me see. So yeah, there's other a lot of these like kind of foams and sponges and those sorts of things. Their goal is to either provide like some sort of spermicidal agent that will kill off sperm cells or release hormones that are going to control different stages of the menstrual cycle. And then we have an intrauterine implantation device, or an IUD. So these IUDs, their goal is to be implanted, at the posterior region of the uterus, and they'll release hormones to do the same thing to be able to control hormonal release to prevent pregnancy. Fun fact about IUDs: family friend of ours a couple of years ago, she had an IUD and she got pregnant, and her baby was born holding the IUD. Kind of funny. So IUDs are, again, None of these measures is considered to be 100% effective, right? So yeah, it's kind of crazy. So none of these measures are considered to be 100% effective. And really, one of the best things that you can do is to use, one of these methods of contraception 100% perfectly, and to time the ovulation part of the menstrual cycle. So if you can time that, then that's the best form of contraception if that's what you're looking to do. Or if you're looking to conceive, then the best thing to do is obviously not use any contraception, and also time when the ovulation part of the menstrual cycle is occurring as well. And then we also have birth control pills. So birth control pills are, a pretty common and pretty effective way of controlling not only the menstrual cycle, but also, the ability to conceive, right? So each of these pills is designed to, release hormones at different stages of the menstrual cycle. And then there's, certain weeks where you have a placebo, which is a sugar pill that doesn't actually do anything, right? Birth control pills are a pretty common way of controlling hormones that control the release of things like luteinizing hormone, follicle-stimulating hormone, estrogen, and progesterone to, control whether or not that egg gets released during the ovulation cycle. Okay. And then in terms of male contraception, there are forms of male contraception that are being developed, like different kinds of chemical contraception. But one of the most common ways to make sure that no male is ever going to be able to reproduce again is something called a vasectomy. Okay, so vasectomy is where a surgeon will go in and surgically cut and tie off. Usually, what they do now is cauterize the ends of the ductus deferens, and then they'll sew everything up, and then you'll be good to go. However, I can tell you from personal experience. I mean, not from me. I haven't had this done or anything, but my father-in-law had a vasectomy done, and he didn't go and get it checked. And now I have two brothers-in-law. Not now, like they're older, but it's kind of funny that like he went and got a vasectomy and didn't have it checked again. Because sometimes what can happen is, even if they're tied off like this, these ties can end up degrading or going away. And these vas deferens have a really funny way of reuniting themselves and reconnecting to be able to provide successive sperm to be able to be released for implantation. Yeah, exactly, right, John? Exactly. Yeah. So yeah, if vasectomy is the route that you're going, you got to make sure that you get it checked out. Okay. And then there's also a similar form of this where if you think of like getting tubes tied, women can undergo a similar procedure where the uterine tubes are cut and tied off as well. Okay. Part of the problem with this, yeah, right. Yes, indeed. Bless up, John. Glad you're here, bud. Hey, glad you're here. Okay. So the females can undergo a similar procedure where the uterine tubes are cut and tied off as well. Okay, so different kinds of STIs and other kinds of infectious diseases. So we have like kind of general pelvic inflammatory disease, or PID, bacterial infection of the female pelvic organs, commonly caused by vaginal or uterine infection with the bacteria, gonorrhea, or chlamydia. Early symptoms include increased vaginal discharge and pelvic pain. Antibiotics can be effective, and if untreated, can lead to sterility or sometimes can be life-threatening. So some of our more common STIs: non-gonococcal urethritis, so inflammation of the urethra that is not caused by gonorrhea and can be caused by trauma, insertion of a non-sterile catheter, or sexual contact, usually due to infection with bacterium Chlamydia trachomatis. And this may go unnoticed and result in pelvic inflammatory disease or sterility. And antibiotics are going to be an effective treatment here. Trichomoniasis, so it's a protozoan commonly found in the vagina of women and the urethra of men, results in a greenish yellow discharge with a foul odor, more common in women than it is in men. Gonorrhea, caused by the bacteria here, gonorrhea, which attaches to the epithelial cells of the vagina or male urethra and causes pus to form. And a painful discharge can form from the penis in men, and it can be asymptomatic in women in the early stages. It can lead to sterility in men and pelvic inflammatory disease in women. And we have different kinds of genital herpes caused by simplex 2 virus, characterized by lesions on the genitals that progress into blister-like areas, making urination, sitting, and walking painful. Antiviral drugs can be effective for this. We can have genital warts, syphilis. So genital warts caused by viral infection, very contagious. Warts vary from separate to small growths to large cauliflower-like clusters. Lesions are not painful, but sexual intercourse with lesions is. Treatments include topical medicines and surgery to remove them. Syphilis, caused by the bacterium Treponema pallidum, can be spread by sexual contact. Multiple stages occur. Children born to infected mothers may be developmentally delayed, and antibiotics are effective. And sometimes if it's untreated in males, it can cause insanity in men as well. And then we have HIV and AIDS. So acquired immunodeficiency syndrome, AIDS, caused by human immunodeficiency virus, HIV, which ultimately destroys the immune system. Transmitted through intimate sexual contact or by allowing infected bodily fluids into the interior of another person. So ingesting things like spit or blood or anything like that will cause the transmission of things like HIV, right? Okay, so yeah, different kinds of tumors. So like with ovarian tumors or uterine tumors, sometimes 75% of tumors tend to be benign in uteruses. Frequent severe menses, strong menstrual uterine cramping are indicative of this, and then usually it's a hysterectomy that's the ultimate treatment here. And this is a common case with internal or with like internal structures like genitalia. For some reason, these structures seem to develop on a regular basis. They tend to develop tumors for some reason. Both ovaries and uteruses tend to develop these. And to be honest, I don't really know why. I don't know if anybody knows why for sure, but it might just have to do with the effectiveness of these structures with age, and how because they're internal, they're kept at higher body temperatures, and there's a lot of moving parts of them, and sometimes they can just develop these tumors as a result. And so you can have different forms of tumors, so subserous, submucous, and then interstitial leiomyomas right here that will form these different kinds of tumors on the uterus. Okay, so we've got a couple minutes left, and I really just wanted to, let me see, we'll stop sharing this. Let me kind of preview a little bit of the embryo stuff for you guys. I'm just going to kind of jot down some notes on a little whiteboard here. Okay, we'll do some text. Whoops. So with embryology or with development, the nice thing about embryology is that there's really only 3 kinds of tissue we have to care about. So we have these different kinds of tissue that we call germ cells or germ layers, which are just layers of cells. This will make next week's lecture go by pretty quickly. So germ layers, there's layers of cells that are all related to one another. And we've got 3 major types. Germ layers. So the first major type is what we call the ectoderm. Oh, I'm nuts. There. So first major type is what we call the ectoderm. Okay. So the ectoderm gives rise to things like the brain, spinal cord, so obviously all nerves. It gives rise to the dentin in your teeth. What else does the neural crest do? Forms different kinds of brain matter, like gray matter, white matter, that sort of stuff. It also forms your epidermis, so your outer layer of skin. That's all derived from ectodermal cells. The outer layer of the skin, rather, not the rest of them, just the outer layer, the epidermis, right? So those outer 5 layers. And then we've also got these other cool cells called neural crest cells, which kind of do lots of stuff. So they form like different kinds of peripheral nerves around the body. They form different regions of the bony structure in your teeth. They can migrate and form different parts of developing nervous tissue like eye cells or ear cells or anything like that. So neural crest cells are pretty nuts. And then we've got our second layer, our second germ layer called the mesoderm. The mesoderm is kind of what we would call like the middle layer. And so this layer mostly develops into things that we call our skeleton, our dermis, so the underlayer of our skin, and then muscle. So most of these structures, and also things like vascular tissue, all are comprised or come from the mesoderm. Things like the mesenteries and peritoneum, so the like parietal, visceral, peritoneum. Let's see. Let's increase our font size. There we go. So the parietal and visceral peritoneum all get developed from the mesoderm. The heart as well, big structure that comes from the mesoderm. And then finally, we have our last layer of cells called the endoderm. And the endoderm is pretty chill because really the only thing that it develops into is the guts. So things like your lungs, intestines, esophagus, trachea, mouth, or oral epithelia. The large intestine, or I'll say like pancreas, gallbladder. Now I put liver here, a little asterisk, because the liver is also developed in part by the mesoderm as well. So the liver is kind of made up of both parts there. So the endoderm is pretty simple because it's just, you know, guts and viscera, but the mesoderm and ectoderm have a little bit more involved stuff. Ectoderm generally just, you could think of like nervous tissue and like the outer layer of your skin. Mesoderm is skeleton, muscle, and your dermis. And then the endoderm is just guts and viscera, right? So, you know, I just wanted to kind of throw this stuff out there, and then you guys can kind of, you know, write some of this down to prepare a little bit for lecture next week. Because next week we're just going to talk a little bit about the developmental process of the embryo, and then, you know, talk about like, you know, when organogenesis occurs, and then different stages of pregnancy, and then like kind of genetic propensity for development, like why are we a blend of our parents and that sort of thing. So yeah, I'll leave this up, and then if you guys have questions, let me pull up the chat here. Sorry. Oh, that's okay, John. Yeah, if you guys have questions about anything, you can let them fly. But otherwise, Tuesday, folks, you guys are good to go. Have an awesome weekend. And then Thursday, folks, if you guys want to stick around for lab at 7 o'clock, really, I'm just going to go over some of the structures of the kidney, talk about some of those, and then if you guys have questions about that stuff, we can cover that. But you are not required to come to lab tonight if you're in the Thursday section, if you don't want to. Okay. So yeah, for the lecture final, that's a good question, Alex. Lecture final and the lab final next week. Actually, let's pull up the syllabus here. Okay. So right here, so we are going to finish up our reproduction and development lecture on Tuesday. We'll finish pretty early, and then Tuesday, folks, you guys will have your lab assessment that night. Okay, so that has to be completed that night. Same thing for the lecture final. Okay, the lecture final needs to be completed I'm going to give you guys until midnight on Friday. I'm sorry, not Friday. F does not stand for Friday, it stands for final. I'm going to give you guys until midnight on Thursday to be able to complete this, just because I have to have grades done and sent over to Crafton relatively soon. So I want to make sure that that gets done. And then same thing for the lab assessment for the Thursday folks. So that'll be done then. Okay. So I hope that kind of answers your question, Alex. The lecture assessment, historically, you guys have had a week to do it, but this time you have to complete the lecture assessment on the day that I assign it, which is Thursday. But the upside is you have until midnight to do it. That's a good question, Amanda. I don't see why I can't, since we don't have lecture that day. Let me check with my department chair and see if it's okay that I do that, because I don't want to give access to the final prematurely if other classes aren't doing the same thing. But that's a really good question. I'll make sure I ask about that. And actually, I'll tell you what, I'll just send an email to him right now while we're here. Yes, and so that's another good question too, Hugo. The final itself is only based around chapters 18, 19, and 20. So urinary system and reproduction and development. That's all the final is based off of. Yeah. So here I'm gonna send an email. Also, I think hopefully a lot of you guys are still here. Yeah. Just really quick. I mean, so when are you posting grades? Yeah. So Leslie, I'm gonna post the grades tonight because I'm the worst person of all time. They're gonna be posted tonight. I apologize for them not getting posted before, but I will get them done tonight. Okay. I do want to say, I don't know how many of you are going to be able to, make it to lecture on Tuesday or anything like that, but this has been such an, roller coaster of a year. But you guys have been an awesome class. Like I've had such an awesome time getting to teach you guys. You guys have been a really fun, interactive class, especially in lecture. I know the exam, like the distance learning stuff has been kind of tough. And it's really easy to just kind of sit back and kind of let me just talk, and you guys get to passively absorb stuff, and then you can watch the YouTube videos later. But I appreciate when you guys ask questions, and I appreciate you guys showing up every Tuesday, Thursday, and just being here. Like you've made the experience good for me. And yeah, like I hope I get to, I hope I get to teach like 150 and 151. And if you guys are still at Crafton and you decide to teach or take those classes, I hope I get to see some of you there. I hope I don't have to see any of you again in this class, right? And I don't think I will, but I think everybody will be in pretty good shape with grades. So I just want to say thank you guys. You guys have been an awesome class, and I really appreciate you guys. So that's all I wanted to say. Um, aw, not a problem, guys. Hmm. Well, it's my pleasure. Like I said, I'm the lucky guy. I get paid to just like sit here and talk about anatomy and physiology, right? Like that's the most fun. But really, like you guys make the class. Like it would be way different if you guys just kind of like never participated or did anything, but that's not the case. Like you guys made it a lot of fun this semester, so I really appreciate that. And yeah, I hope I tried to do the best I could, especially with all of this, and it's just tough because there's a lot of stuff we got to talk about. But regardless, in the future or whatever, come on by the adjunct office, whenever you can, just to kind of hang out or make fun of me or whatever, and just I'd love to see all of you guys at some point when we get back to some amount of normalcy. So yeah, like I'd like to do that. Yeah, I'm hoping I get to teach 150 as well. So okay, so yeah, let me so Amanda, I'm going to send that email and ask about posting the exam early. but yeah, thank you guys. You guys are you are awesome. All right. And feel free, if you have questions or if you need like, letters of rec or anything like that, you can always reach out and ask me. I'd be happy to do that for you guys. So um, okay, cool. I'm gonna send that email as I like keep talking about it and then I don't do it.
Hold on, don't say.
Oh, wait.
I have a question. Are you going to be posting this on YouTube as well?
Sorry, what'd you say, Leslie?
Are you going to be posting this on YouTube?
Yes. So I know, like, I'm literally the worst. I didn't post the last lecture either. But yes, I'm gonna get that posted tonight as well. Actually, while we're kind of done, I'm gonna make sure I get that posted tonight in between this and lab. So yes, they will both be posted.
Awesome. All right. Thank you.
Yeah, you're welcome. Okay. Yeah, I know. I'm sorry, Lewis. Yeah, high schoolers are good kids. It's so funny because they're just so burnt out. No, so Daniel, we do have lecture on Tuesday. We're gonna finish up chapter 20. We're just kind of, shooting the stuff right now. But yeah, my high schoolers are so burnt out. My seniors, tomorrow is technically their last day. But yeah, like they're ridiculous. They're so tuned out. Like, so, you guys are really active in the chat, even though like, sometimes, people chime in on the mic or whatever, but man, my freshmen, it's like the only way that they communicate is through like the like emote icon on Zoom. They don't like, say anything ever. I see them like they're there, but but they never respond or anything. Okay. Okay. Well, cool guys. So I'm going to stop sharing. All right. So we'll also stop recording.